Hey everyone, thank you for listening to our presentation. This is Tristan Stovall, and I'm going to start us off today. Our topic is oral versus intravenous rehydration therapy in pediatric acute gastroenteritis. Acute gastroenteritis is characterized by inflammation of the stomach and intestines caused by viruses, bacteria, or parasites, most commonly through fecal-oral transmission. Pathogens damage the intestinal epithelium, leading to villus atrophy, decreased nutrient absorption, and impaired water absorption. This results in watery or inflammatory diarrhea, vomiting, and abdominal pain. This is well represented in the images on our poster. The image on the far right shows the pathophysiology of acute gastroenteritis pretty well. It shows how pathogen introduction leads to inflammation and the villus atrophy I mentioned earlier, causing intestinal damage. This leads to worsened fluid absorption, causing fluid loss either by vomiting or diarrhea. The images above and below show how a gastroenteritis can be caused by numerous bacteria and viruses. Acute gastroenteritis, or AGE, is a very common condition in children and often leads to dehydration. Because of this, children frequently come to the emergency department needing treatment. Traditionally, many providers in the U.S. use IV fluids because they are seen as faster or more effective. However, research shows that oral rehydration therapy, or ORT, is actually recommended as a first-line treatment for mild to moderate dehydration. Despite this, IV therapy is still being overused due to non-clinical factors such as parental expectations and perceived provider efficiency. This creates a gap between what research recommends and what is actually happening in practice. So our goal with this project was to explore which method is more effective, safer, and better for patients and the healthcare system. This led us to our PICO question. In pediatric patients with mild to moderate dehydration from gastroenteritis, how does a nurse-led oral rehydration pathway with ondansetron compared to IV therapy affect hospitalization rates, length of stay, and complications? A search was conducted using databases like PubMed, CINAHL, Embase, and Google Scholar. Key terms included pediatric gastroenteritis, oral rehydration therapy, IV fluids, ondansetron, dehydration, and children. We focused on peer-reviewed studies involving pediatric patients, specifically those comparing oral and IV rehydration or the use of ondansetron. Most of the studies were published within the last 5 to 7 years. Studies involving only adults, severe dehydration only, or non-English articles were excluded. In total, 5 high-quality studies were selected, including randomized trials and comparative analyses. Now I'll hand it off to talk more about the problem.
Hi, my name is Angela Hadley, and I am going to talk about the problem and its significance. One of the biggest problems we identified in the literature is the overuse of intravenous or IV fluids, even in cases where they are not clinically necessary. Current evidence clearly supports oral rehydration therapy, or ORT, as the first line treatment for children with mild to moderate dehydration. However, despite these guidelines, many providers still default to IV therapy in practice. There are several reasons for this. First, provider habits and clinical culture play a big role. In many emergency departments, IV fluids are seen as the faster and more efficient option, even if that is not supported by outcomes. Second, parental expectations can influence decision making. Many parents associate IV fluids with stronger and more effective care, especially if their child appears very ill. This can create pressure on providers to choose IV therapy, even when oral rehydration would be appropriate. Third, there is often a concern about speed and control of treatment. IV fluids can appear to correct dehydration more quickly, which may make providers feel more confident in acute settings. However, the research shows that faster rehydration does not necessarily lead to better overall outcomes. Because of these factors, IV therapy is frequently used when it could be avoided, and this leads to several important consequences. There are increased healthcare costs. IV therapy requires more supplies, more staff time, and often leads to hospital admission, all of which increase the financial burden on the healthcare system. Patients who receive IV fluids tend to have longer hospital stays. Even though IV rehydration may work faster initially, it does not translate to quicker discharge or recovery. It also exposes children to unnecessary invasive procedures. Starting an IV can be difficult and distressing, especially in pediatric patients, and often requires multiple attempts. There are also specific clinical risks associated with IV therapy, including infection at the insertion site, phlebitis, which is inflammation of the vein, infiltration, or fluid leaking into surrounding tissue. In addition to physical risks, there is also a significant emotional impact. IV insertion is often reported as one of the most painful and stressful experiences for children in the hospital. This can affect how they respond to healthcare in the future. From a broader perspective, this issue also has a major economic impact. Research shows that avoidable hospitalizations related to pediatric gastroenteritis cost the U.S. healthcare system millions of dollars each year. Much of this cost is linked to the overuse of IV therapy when oral rehydration could have been used instead. So overall, this is not just a clinical decision, it is a multi-faced problem that affects patient safety, healthcare costs, research utilization, and overall quality of care. Because of this, it is essential to evaluate how we can reduce unnecessary IV use and better align clinical practice with current evidence. This is where evidence-based interventions, especially nurse-led protocols, and the use of oral rehydration can make a significant difference. Now that we've discussed the problem and why it matters, we'll move on to what the research shows about the effectiveness of these treatment options.
Hi, everyone. My name is Lee Ann Moore, and I'm going to talk about the clinical effectiveness and safety. When comparing oral and IV rehydration, the research is very clear. Both methods are equally effective for mild to moderate dehydration. One study did show that it had a 100% success rate for both ORT and IV fluids. The IV worked slightly faster, but ORT resulted in shorter hospital stays. This is actually important because faster treatment does not always mean better outcomes. I'm now going to talk about the rebound effect as far as a clinical depth perspective. Interestingly, research also highlights that while IV rehydration works quickly, it does not necessarily address the ongoing fluid loss as effectively as ORT does. ORT encourages the gut to begin absorbing nutrients and electrolytes immediately, which can actually prevent the rebound dehydration that sometimes happens after an IV is removed. When it comes to safety, IV therapy has complications in about 10% of patients, like infection or infiltration, which we've talked about. It is also one of the most painful procedures for children. On the other hand, ORT's main issue is vomiting, but this is usually mild and temporary. Overall, ORT is just as effective, safer, and less invasive. So when we look at the data, the speed of an IV is often a clinical illusion. It might fill the tank faster, but it does not get the patient home sooner or safer. By choosing ORT, we're choosing the path of least resistance and highest safety. There is a nursing perspective, or we'll talk about the psychosocial impact on children. Beyond the physical safety, we have to consider the psychological impact. An IV often requires immobilization or splinting of a child's arm, which increases anxiety and limits their ability to comfort themselves. ORT allows the child to remain in their caregiver's arms, drinking from a familiar cup, which significantly lowers the stress levels for both the patient and the parent. Now we'll talk about the cost and system impact.
Hi, I'm Coco Mueller, and I'm going to talk about the cost, efficiency, and ondansetron. Beyond patient outcomes, the choice between ORT and IV therapy also affects the healthcare system. Research shows that ORT is more cost-effective, it reduces emergency department congestion, and it shortens hospital stays. Starting with ORT saves money without reducing quality of care. One barrier to ORT, though, is vomiting. This is where ondansetron comes in. Ondansetron is an anti-nausea medication that reduces vomiting and helps children tolerate oral fluids. Studies show it reduces the need for IV fluids by 79%, and it reduces hospitalizations by 56%. What's even more interesting, that oral ondansetron works better than injections. So combining ORT with ondansetron greatly improves success rates. Now we'll talk about what this means for nursing practice.
Hi everyone, my name's Madison Roney, and I'm just going to talk about the nursing implications and conclude us out. So first, we can look at our picture of the ORT pathway that we put on our poster. This just allows nurses to see a visual of how we can assess and go through all of this. So when we have a patient, we want to assess them for which dehydration they have, either if it's mild or moderate. And then we'll go into administering the ondansetron, and then we'll initiate the oral rehydration therapy. After that, we'll reassess the hydration status, and then if we see that it is not improving, that is when we can move into our IV fluids and go from there. So the research has strong implications for nursing practice. Some major takeaways is that it promotes ORT as the first-line treatment for mild to moderate dehydration. It implements nurse-led protocols to standardize care, the use of ondansetron to improve ORT success rates, reduce unnecessary IV insertions and related complications, decreases emergency department length of stay and healthcare cost, improves patient comfort, safety, and overall outcomes, and educates patients and caregivers about the effectiveness of ORT. Nurses play a major role by using standardized nurse-led protocols, which allows nurses to start ORT and give ondansetron early, reducing delays in IV use. Caregiver education is also very important. Many parents believe IV fluids are better, so nurses must be able to explain that ORT is just as effective and it is safer and less painful. Nurses should also be able to use tools like the clinical dehydration scale. This scale helps make objective decisions instead of relying on guesswork. Finally, this supports resource stewardship, meaning lower costs, shorter hospital stays, and better patient flow. Talking about the implementation and sustainability of it all, moving forward, the goal isn't just to know the research, but to also change the culture of the emergency department. Some policy change is we can advocate for integration of ORT and ondansetron into standing orders. So this empowers nurses to initiate the care the moment the child is triaged, rather than waiting for physician's order for an IV. And some visual aids that we can use is suggest using success stories or visual infographics in the waiting rooms to show parents that ORT is the gold standard and not just a second-tier treatment. This can also reassure them that not IV fluid is the best way to go. Overall, oral rehydration therapy should be the first-line treatment for mild to moderate dehydration in children. It is equally effective, safer, less invasive, and more cost-effective. Improving education, protocols, and nursing involvement can help close the gap between research and practice. Thank you all for listening.